Cortisol is the hormone your body was designed to release in short bursts when danger is present, when illness strikes, when a physical threat demands an immediate physiological response. In those short bursts, it is life-saving. It sharpens attention, raises blood sugar for rapid energy, suppresses inflammation to allow action, and prepares every system in your body to either fight or flee. The problem that affects millions of older adults, particularly women, is not the acute burst. It is the chronic elevation. Cortisol that never fully returns to baseline because the stressors are not predators or emergencies, but the relentless accumulation of chronic pain, social isolation, sleep disruption, financial worry, health concerns, and the psychological burden of aging. Demands that do not resolve in minutes, but persist for months or years. According to the Frontiers in Endocrinology review on adrenal aging, normal aging itself results in a general increase in mean daily serum cortisol levels in the elderly. The chronically elevated glucocorticoid levels documented in aging populations can have serious consequences for the structural and functional integrity of key brain areas, including the hippocampus, amygdala, and prefrontal cortex, with consequent impairment in memory, cognitive function, and sleep cycles. According to the PMC review on stress, inflammation, and aging, HPA axis dysregulation, the stress hormone regulation system that governs cortisol, has been implicated in several late-life disorders, including anxiety, major depression, and cognitive impairment. According to a PMC study on cortisol in older adults with generalized anxiety, older adults with elevated anxiety had cortisol levels approximately 40 to 70% higher than age-matched adults without anxiety. The 11 signs in this video are not limited to the rare clinical condition of Cushing syndrome, the formal diagnosis of cortisol excess caused by a pituitary or adrenal tumor. They apply to the far more common pattern of chronic hypercortisolemia from persistent stress, poor sleep, and the physiological changes of aging, a pattern that affects a substantial proportion of adults over 60 and that produces the same body-wide damage as clinical Cushing's, just more slowly and more quietly. According to NCBI Stat Pearls, chronic hypercortisolism disrupts homeostatic regulation across multiple organ systems, including metabolic, cardiovascular, musculoskeletal, immune, and neuropsychiatric systems, contributing to visceral adiposity, proteolysis, insulin resistance, arterial hypertension, decreased bone mineral density with increased fracture risk, immunosuppression, and cognitive and mood disorders. This is what chronically elevated cortisol does to the body over years. These are the 11 signs it leaves behind. This video is for educational purposes only. A salivary cortisol test, 24-hour urine-free cortisol test, or blood cortisol test ordered by a physician can confirm whether cortisol levels are genuinely elevated. If you recognize multiple signs on this list and cannot attribute them to other identified causes, bring this list to your physician and ask for cortisol evaluation. Sign number 11, difficulty falling asleep, waking during the night, or waking too early in the morning and being unable to return to sleep, despite being genuinely tired, with sleep that feels unrefreshing even when it technically occurred for an adequate number of hours. An older woman lying in the dark at 2 a.m., eyes open, mind moving through a list of concerns she cannot stop, having been awake since 1:30, despite having been tired when she went to bed at 10. Cortisol follows a specific circadian rhythm in healthy adults. It peaks in the early morning, typically between 6 and 8 a.m., giving the body the alert, ready signal that initiates the day, and it falls to its nadir near midnight, allowing the brain and body to shift into the restorative sleep state. According to NCBI Stat Pearls Cortisol Physiology Review, this circadian rhythm is well defined when the system is functioning normally, with peak levels in early morning and the lowest point near midnight. When cortisol is chronically elevated, two things go wrong with this rhythm simultaneously. The daytime cortisol fails to fall normally in the evening, keeping the nervous system in an alert, aroused state that makes sleep initiation difficult. and the nighttime nadir fails to reach the low point it should, so the body's sleep stage transitions are disrupted and the person either cannot stay asleep or wakes far earlier than intended with a cortisol surge that the body has begun releasing prematurely. According to Yale Medicine's Cortisol and Cushing's overview, poor sleep is listed among the documented symptoms of cortisol excess alongside fatigue, weakness, and cognitive changes. According to the PMC review on stress and aging, stress-related inflammation has been specifically implicated in insomnia and cognitive decline in older adults. The sleep disruption from cortisol is self-reinforcing. Inadequate sleep raises cortisol the following day, which further disrupts the next night's sleep, creating a cycle that cannot be resolved by discipline or routine alone because the hormonal driver remains unaddressed. Sign number 10, persistent fatigue and a low energy level that does not improve with rest, that is present throughout the day rather than building toward evening, and that has gradually worsened over months without a new illness or significant increase in physical demand to explain it. An older man who used to begin the morning with energy and gradually tire through the afternoon, now finding that the fatigue is present from the moment he wakes, as though the sleep provided no restoration at all. Chronically high cortisol produces fatigue through a mechanism that is the opposite of what people intuitively expect from a hormone associated with alertness and activation. While acute cortisol produces a temporary energy surge, the chronic elevation depletes the body's energy reserves by driving sustained metabolic demand, continuously burning glucose, breaking down protein, and suppressing the anabolic processes that rebuild and repair tissue. The adrenal glands themselves can become fatigued by the sustained demand for cortisol production. According to Healthline's clinical overview of high cortisol symptoms, high cortisol can cause persistent tiredness that might seem odd for a hormone associated with stress activation, but it can wear out the adrenal glands and lead to feeling very tired and sluggish. According to Yale Medicine, fatigue and weakness are specifically listed among the documented symptoms of cortisol excess in the clinical classification of Cushing syndrome. The crucial distinction from ordinary tiredness, this fatigue does not resolve with a good night's sleep or a restful day because its cause is not insufficient rest, but sustained hormonal overactivation of the body's stress response system. Sign number 9, unexplained weight gain concentrated specifically in the central abdomen, a rounding and expansion of the waistline that has occurred without a change in eating habits, and that has been resistant to dietary attempts to address it, sometimes combined with the appearance of relatively thin arms and legs compared to the expanded trunk. An older woman who has worn the same dress size for decades, now finding that waistbands of previously comfortable clothing no longer close, despite eating the same diet she has maintained for years and walking daily. Cortisol drives visceral fat accumulation, the storage of fat specifically around the abdominal organs, rather than subcutaneous fat stored just beneath the skin, through a direct mechanism. Cortisol acts on receptors in visceral adipose tissue, the fat depots surrounding the abdominal organs, stimulating fat storage there, while simultaneously driving the breakdown of fat in peripheral deposits and the catabolism of muscle in the limbs. According to NCBI StatPearl's Cortisol Physiology Review, excessive cortisol exposure produces central obesity alongside muscle wasting, hypertension, and glucose intolerance. According to Wikipedia's comprehensive Cushing syndrome overview, abdominal obesity with thin arms and legs is a documented feature of prolonged cortisol excess. According to the PMC Cortisol Dysregulation Review, chronic stress and HPA axis dysregulation are expressed in truncal obesity and insulin resistance. The specific distribution, central expansion with relative thinning of the arms and legs, is the body's adipose tissue responding differently to cortisol signaling in different fat depots, and it is clinically recognizable as a cortisol-driven pattern rather than ordinary age-related weight redistribution. Sign number 8, a new fatty deposit at the back of the neck and upper back, between the shoulder blades or at the base of the neck where it meets the shoulders, that has appeared or grown more prominent over months, and that feels like a soft pad of tissue over an area where fat does not normally accumulate significantly. An older woman noticing that her blouses no longer drape the same way across her upper back, that a rounded softness has appeared at the base of her neck and upper shoulders that was not present before, and that a friend or family member has asked what the swelling at the back of her neck is from. This sign, known clinically as a dorsocervical fat pad or colloquially as a buffalo hump, is one of the most specific physical signs of prolonged cortisol excess. Unlike the diffuse subcutaneous fat of ordinary weight gain, this deposit is regionally specific. It develops at the back of the neck and between the shoulder blades as a direct consequence of cortisol's effect on fat distribution, redirecting fat from peripheral sites to central and dorsal deposits. According to Cleveland Clinic's Cushing syndrome clinical overview, increased fat at the back of the neck or between the shoulders, sometimes called a buffalo hump, is a specifically listed sign of Cushing syndrome and cortisol excess. According to Wikipedia's Cushing syndrome overview, growth of fat pads along the collarbone and on the back of the neck is listed among the common signs of prolonged glucocorticoid excess. This sign is consistently missed in older adults because it develops slowly enough to be attributed to the general weight gain of aging, but its regional specificity, appearing at the back of the neck and upper back rather than distributed generally, is the distinguishing feature that points toward cortisol as the driver. Sign number 7. Muscle weakness in the large muscles of the upper legs and upper arms. Difficulty rising from a chair without using the arms. Difficulty climbing stairs. Reduced ability to lift arms overhead for activities like reaching into high cabinets, combined with aching or soreness in the joints of the hips, shoulders, and lower back. An older woman who has started using the handrail every time she climbs stairs, not because of balance or pain in the knee joints themselves, but because her thighs simply do not seem to have the strength they used to, attributing the change entirely to age-related muscle decline rather than considering whether a hormonal process is accelerating it. Cortisol at chronically elevated levels drives protein catabolism, the breakdown of muscle protein to release amino acids into the bloodstream as a fuel source. The muscles most affected are the large proximal muscles, the quadriceps, hip flexors and gluteal muscles of the lower extremity, and the deltoids and biceps of the upper extremity. According to Washington University's clinical overview of high cortisol and Cushing syndrome, proximal muscle weakness, particularly in the thighs and upper arms, is a documented and characteristic feature of hypercortisolism. According to Wikipedia's Cushing syndrome overview, proximal muscle weakness in the hips and shoulders is listed specifically as one of the striking physical features of prolonged cortisol excess. According to the PMC review on adrenal aging and cortisol, glucocorticoid excess is associated with loss of muscle mass as one of the major age-related changes amplified by elevated cortisol in elderly populations. The joint aching component occurs because cortisol simultaneously suppresses the anabolic processes that maintain cartilage and synovial fluid, making joints feel sore and stiff in addition to the muscular weakness. Sign number 6. Skin that has become thinner and more fragile than before, bruising easily from minor contact that would not previously have caused bruising, cuts and abrasions that take noticeably longer to heal than they used to, and purple or pinkish stretch marks appearing on the abdomen, hips, or breasts without significant weight gain, alongside an overall coarsening and dryness of the skin texture. An older woman who notices a large bruise on her forearm from what she recalls as a very minor bump against a door frame, looking at the bruise and remembering how much longer it seems to be taking to fade than bruises from similar contact used to take. Cortisol at chronically elevated levels degrades the collagen network in the skin. Collagen provides the skin's structural strength, elasticity, and thickness. When cortisol continuously suppresses fibroblast activity and collagen synthesis, the dermis becomes progressively thinner and more fragile. The small blood vessels near the skin surface lose their protective collagen scaffolding, and the capillaries rupture from minor trauma that previously would not have been sufficient to cause visible bleeding under the skin. According to Cleveland Clinic's Cushing syndrome overview, skin changes like easy bruising and wounds that heal poorly are specifically listed signs of cortisol excess. According to Wikipedia's Cushing syndrome clinical description, thinning of the skin causing easy bruising and dryness, particularly of the hands and mucous membranes, is a striking feature, alongside purple or red stretch marks on the trunk, buttocks, arms, and legs as the weakened skin stretches and hemorrhages. The slow wound healing occurs because cortisol
suppresses the immune and inflammatory response that initiates the healing cascade. The same mechanism that makes cortisol temporarily effective as an anti-inflammatory medication also, over time, impairs the body's ability to repair injured tissue. For seniors over 60, this sign is almost universally attributed to the natural thinning of aging skin rather than to the hormonal process that may be dramatically accelerating it.
Sign number 5. High blood pressure that has appeared or worsened without a clear cardiovascular explanation, or that has been difficult to control despite medication, combined with occasional heart racing or pounding sensations that appear without physical exertion. An older man whose blood pressure readings at his last several appointments have been higher than his physician expects given his medication regimen, being told to reduce his sodium intake further without any inquiry into whether a hormonal factor might be driving the resistance. Cortisol has direct and indirect effects on blood pressure through multiple simultaneous mechanisms. It acts on blood vessel walls to increase their sensitivity to the vasoconstrictive effects of catecholamines like epinephrine, causing vasoconstriction, the narrowing of blood vessel diameter that raises peripheral resistance and blood pressure. It drives sodium and water retention through the kidneys, increasing blood volume and further elevating pressure. According to NCBI StatPearl's hypercortisolism review, arterial hypertension is a documented consequence of chronic cortisol excess. According to the PMC cortisol dysregulation review, stress-induced raised cortisol levels lead to risk factors implicated in cardiovascular pathology, including raised blood pressure, and prolonged long-term stress affects blood clotting. Blood becomes stickier, increasing the incidence of stroke. For seniors over 60 on blood pressure medications whose readings remain persistently elevated despite treatment, a cortisol evaluation is a clinically reasonable investigation when other cardiovascular causes have been assessed and controlled. Sign number 4. Anxiety, irritability, or a sense of persistent unease that is new or has worsened, feeling unable to relax even in objectively safe and comfortable situations, finding that minor stressors produce a response that seems disproportionate, and noticing that the ability to feel calm and settled that was present at younger ages now seems inaccessible. An older woman who has always been known for her calm, patient temperament, now finding herself irritable with family members over small things, unable to fully unwind even during quiet evenings, and describing to her physician a general background anxiety that feels like her nervous system is set too high. According to Yale Medicine, irritability, depression, mood swings, and anxiety are documented symptoms of cortisol excess. According to the PMC Review on Stress and Aging, HPA axis dysregulation has been specifically implicated in late-life anxiety and major depression as disorders driven, at least in part, by chronic cortisol elevation. The mechanism is the direct action of cortisol on the amygdala, the brain structure that processes threat and emotional reactivity. Chronically elevated cortisol sensitizes the amygdala's threat response, lowering the threshold at which the brain interprets situations as threatening, and reduces the effectiveness of the prefrontal cortex's regulatory control over that response. The result is a nervous system that stays in a low-grade alert state, even when there's nothing objectively alarming present. What is experienced subjectively as anxiety, irritability, or an inability to fully relax. Sign number 3. Frequent infections, slow recovery from illness, or infections that are more severe than they used to be, colds that take longer to clear, recurring urinary tract infections, skin infections that do not heal as expected, or being noticeably more susceptible to whatever is circulating among family members or social contacts. An older woman who used to recover from a winter cold in a week and is now finding that each illness lingers for 2 to 3 weeks and leaves her feeling depleted far longer than she expects. Cortisol, at chronically elevated levels, suppresses the immune system. This is, again, a feature of cortisol that is protective in the short term. Acute cortisol suppresses the inflammatory response,
to prevent it from becoming excessive during a survival emergency. But chronically, the same suppression depletes the immune system's capacity to mount adequate responses to pathogens. According to the PMC review on adrenal aging and cortisol, hypercortisolemia is associated with diminished normal cell-mediated immunity, decreased cytokine production, and loss of normal lymph node mass in elderly populations. According to NCBI stat pearls, immunosuppression and increased susceptibility to infections are documented consequences of chronic hypercortisolism. According to Yale Medicine, Cushing syndrome, the formal cortisol excess diagnosis, specifically increases the risk of opportunistic infections and poor immune response. In seniors over 60, whose immune systems are already partially diminished by the natural process of immunosenescence, the additional immune suppression from chronically elevated cortisol can produce a combined vulnerability that makes infections disproportionately frequent and severe.
Sign number 2. Elevated blood sugar, or a new diagnosis of prediabetes or type 2 diabetes that has appeared without a dietary explanation. Rising fasting glucose readings over successive months, a hemoglobin A1C that has moved into the prediabetic or diabetic range without significant changes in food intake, or increasing difficulty controlling blood sugar that was previously well managed. An older woman reviewing her blood test results at a physician appointment, learning that her fasting glucose has risen to 112 milligrams per deciliter in the prediabetes range, despite having made no changes to her diet and having been within the normal range at her previous test, and being advised to watch her carbohydrates more carefully when the actual driver of the glucose change is hormonal. Cortisol raises blood glucose through two simultaneous mechanisms. It stimulates gluconeogenesis in the liver, the production of new glucose from amino acids and other non-carbohydrate sources, releasing that glucose into the bloodstream even without any dietary carbohydrate input. It simultaneously reduces insulin sensitivity and peripheral tissues, meaning that cells throughout the body become less responsive to the insulin signal that tells them to take glucose out of the blood. According to NCBI Stat Pearl's Cortisol Physiology Review, cortisol influences glucose availability through protein catabolism and gluconeogenesis alongside lipolysis, the complete metabolic picture of a hormone that mobilizes stored energy and resists cellular glucose uptake. According to Washington University's Cushing syndrome clinical overview, development of diabetes and difficulty controlling existing diabetes are listed as metabolic complications of prolonged high cortisol levels. For any senior whose blood glucose or A1C has risen without an adequate dietary explanation, cortisol evaluation is a clinically relevant and often overlooked component of the metabolic investigation. Sign number 1. Memory problems, difficulty concentrating, or cognitive changes that have appeared or worsened over months, forgetting recent conversations or events, losing the thread of complex thoughts mid-execution, or finding that mental processing feels slower and more effortful than it used to, in a pattern that fluctuates rather than declining steadily. An older man who has been attributing his increasing word-finding difficulty and recent forgetfulness to the normal cognitive changes of aging, not knowing that the hippocampus, the brain's primary memory structure, is one of the tissues most directly and most severely damaged by chronically elevated cortisol. The hippocampus has an exceptionally high density of glucocorticoid receptors. This means it is exquisitely sensitive to cortisol, and chronically elevated cortisol produces direct structural damage to hippocampal neurons, reducing dendritic branching, impairing synaptic plasticity, and in sustained hypercortisolemia, measurably reducing hippocampal volume.
According to the PMC review on adrenal aging and cortisol, glucocorticoid excess seen in the elderly population can have serious consequences in both the structural and functional integrity of the hippocampus, amygdala, and prefrontal cortex, with consequent impairment in normal memory and cognitive function. According to the Frontiers in Aging Neuroscience review on high cortisol and dementia risk, There is a growing body of evidence that increased cortisol may be associated with an increased risk of cognitive decline and dementia, and in patients with Alzheimer's disease, increased cortisol at preclinical and early clinical stages is associated with a poorer prognosis and more rapid cognitive decline. This means that the cognitive changes attributable to cortisol are not merely the inconvenience of stress-related brain fog. They are a biological process of hippocampal damage that, if the cortisol elevation continues, may accelerate neurodegenerative decline in a way that cannot be reversed once the damage is sufficient. The bone loss component of chronic cortisol elevation deserves a brief mention before the testing guidance, because it is one of the most medically consequential long-term consequences that is almost never discussed in the context of stress. Cortisol directly inhibits osteoblast activity, the cells responsible for building new bone, while simultaneously increasing osteoclast activity, the cells that break bone down. The result is accelerating bone mineral density loss on top of whatever age-related bone loss is already occurring. According to NCBI StatPearls, decreased bone mineral density with increased fracture risk is a documented consequence of chronic hypercortisolism. For women over 60 who are already at elevated osteoporosis risk, the additional cortisol-driven bone loss can substantially increase fracture risk without the density loss ever being attributed to its hormonal cause. The testing is straightforward. A late-night salivary cortisol test, collecting a saliva sample at 11 p.m. when cortisol should be at its lowest, is one of the most sensitive and least invasive initial screening tools for sustained cortisol elevation, because normally functioning cortisol regulation produces very low salivary cortisol at that hour, and an abnormally elevated result indicates that the evening nadir is failing to occur. A 24-hour urine-free cortisol test provides an integrated measure of cortisol production across the entire day. A morning blood cortisol test assesses peak levels. Any of these tests can be requested from a primary care physician when multiple signs from this list are present. The lifestyle interventions that measurably reduce cortisol are also worth beginning immediately. Consistent sleep scheduling that respects the circadian rhythm, regular moderate exercise, not high-intensity training which raises cortisol further, diaphragmatic breathing exercises that activate the parasympathetic nervous system, and reducing caffeine intake, particularly in the afternoon and evening. These are not alternatives to medical evaluation. They are parallel strategies that lower the chronic cortisol burden while the investigation proceeds. Watch the next video on screen right now.